Hello and welcome to the ESC Congress 2020 in Amsterdam, to the digital experience of science and education. My name is Gerhard Hindricks from the Heart Center Leipzig in Germany, and it's my privilege to share with you the daily wrap-up of the ESC Digital Experience Congress here in Amsterdam. I have the privilege to have two expert colleagues with me that will guide us through the daily wrap-up, and I warmly welcome Professor Silvia Priori from Pavia, Italy, also the program chair of this Congress, and Isabelle van Gelder, Professor of Medicine from Groningen University in the Netherlands. So welcome and thank you for joining us. What an experience. We have almost 100,000 registrants for this digital event organized by the European Society of Cardiology. And we have the latest science and the latest news from guidelines prepared for you. The first day of such events is always very important because it sets the road for the whole event. And I can share with you that as the first day has almost passed by, that it was a brilliant day for science and education. We will discuss new clinical trials, late breakers, and also new guidelines. There are a couple of simultaneous publications at New England Journal of Medicine from the science that has been presented today. And I would like to start off with the Explorer HCM trial. Silvia, what was the aim of Explorer HCM and what was the basic structure of that trial?
Yeah, it's very exciting because, you know, it's not common. Actually, this is one of the first experience in having a drug designed for a rare disease. And the rare disease in this case is hypertrophic cardiomyopathy, a genetic disease that actually is not so rare, estimated to be 1 in 500 persons. So the drug is called mavacamten and is the first one in a class of drugs that act on myosin by preventing the formation of the myosin-actin cross-binding that occur in the patients with hypertrophic cardiomyopathy and lead to the hypercontractility.
And what did the investigators do with that drug?
Yeah, with the investigator are treating a subgroup of patients, very severe patients with subaortic obstruction that creates a gradient between the ventricle and the aorta. And that gradient today is actually dealt with mainly with a drug, the disopyramide, that has several limitations, including tachyphylaxis, so the effect fades over time, and surgery. So most of the severely affected patients go to surgery. The objective of the study is to see whether the drug that was given to patients in New York Heart Class 2 and 3 who presented a gradient above 50 millimeters of mercury. So to see whether we can have benefit, you know, and the primary endpoint, there were two combinations of how to make it the primary endpoint, was an increase in the VO2 max of 1 to 1, more or equal to 1.5 milliliter kilogram minute, and improvement of the functional status. So the primary endpoint could also be achieved by having more than 3 milliliter kilogram minute without having a worsening of the contractility and the New York Heart class. So interestingly, 36% of the patients randomized to the drug met the primary endpoint versus 17% in the control group.
So it's a tremendous benefit.
It's a tremendous benefit. Even more, though, if you think that both endpoints were also met by 20% of the population treated versus only 7.8% of the untreated ones.
Was there any downside with respect to side effects?
Well, there was an 8% of patients were reported with side effects, but we do not know exactly the details of the side effects. So this, of course, you know, is something that will have to be explored, but 8%, you know, is not negligible, but definitely considering the unmet need of these patients. The surgery as an alternative, I think, is a spectacular result.
And it's a brand new medical concept to go into that direction.
Exactly. Do you think that there is a new class of drugs? And, the hope is that, as always, for rare diseases, we start there, but we hope that we can use this class of drugs for other indications in the common set of conditions.
Isabelle, what is your perspective on Explore HCM with a clinical?
I think, as Silvia explained, it is an important step forward for the very symptomatic patients with an hypertrophic cardiomyopathy. Now they have to undergo ablation because disopyramide is often not tolerated. And this drug is the adverse events are rather low. So for my patients who are severely symptomatic, it is an enormous step forward. I'm looking forward to treat them.
Excellent. We need to move on to the next highlight that has been presented today, which was the Emperor-reduced trial, a heart failure trial introducing results on SGLT2 inhibitors. Isabelle.
Well, indeed, it was a large trial, over 3,700 patients who were randomized either to empagliflozin, EMPA, or not, on top of optimal heart failure medication. It was more or less a comparable trial as the DAPA-HF, but there was a difference. These patients had even a poorer LV function, a higher NT-proBNP. It was really enriched for more HFrEF patients. And in the end, the primary outcome was cardiovascular death or the first heart failure hospitalization, 25% reduction. Enormous reduction on top of maximal therapy. And there were also two secondary endpoints, total number of hospitalizations and a decline in the slope of the renal function. And that was also significantly in favor of the actively treated group of patients. So in fact, what they also did was they compared DAPA-HF with EMPA-HF, and more or less they showed comparable results. What we now do have are two trials with SGLT2 blockers who are positive in patients with HFrEF. And also in the EMPA, in this trial, they looked at patients with diabetes and without, and it was comparable for both groups. So it is not only for diabetes, also for patients with HFrEF and no diabetes.
So Silvia, is that another major breakthrough for heart failure with a reduced ejection fraction patient?
Of course, it is. And, we are seeing that this is now going, as Isabelle said, toward a solid confirmation of the DAPA-HF trial. And I think that, seeing this effect, these drugs being effective in more and more compromised patients is really important for all of us. And actually, for the audience, we will have more sessions discussing the positioning of these compounds and the impact they are making. So keep an eye on that.
Great and important information. We now need to turn to the field of atrial fibrillation, because this day here in Amsterdam was also intensely driven by AF, the AF guidelines and the EAST trial. Isabelle, what was EAST about and what was the key message from EAST?
Well, very exciting trial. EAST is patients with early atrial fibrillation were randomized either to rhythm control or rate control. And that were both strategies. So more or less comparable to the RACE, to the AFFIRM, the AF-CHF, and possibly also to CABANA. But it was a different group of patients. These were all patients with at least 2 cardiovascular risk factors. So it were elderly patients. The mean CHEST-FAST was 3.4. And importantly, the duration of atrial fibrillation, the history of AF was very, very short, just shortly over 1 month. And I think that is an enormous difference with all the other rate versus rhythm control trials. And those patients were randomized, were treated with rhythm control or usual care. And it turned out that the primary outcome, cardiovascular death or hospitalizations for heart failure or acute coronary syndrome or the occurrence of stroke, was, and that's for the first time, significantly lower in the rhythm control arm.
Yeah, that's really interesting. And I mean, this is a special day for electrophysiologists, cardiologists active in the field of atrial fibrillation, as we have the EAST trial published today, and we also have the 2020 atrial fibrillation ESC guidelines published today. Let's take a look to the ESC AF guidelines. If you could mention three main steps taken from the AF guidelines, what would be your calls?
Well, I think a main step is that we now look further than only the EKG. We have the 4S score, which is about stroke prevention, symptoms, AF burden, and the substrate. So we have a more holistic approach. And then we introduced, and we try to keep it as simple as possible, the ABC score. Avoid stroke, start anticoagulation, better treatment of symptoms, and treat also the cardiovascular morbidities and mortalities. And finally, another important point is that patients are now more involved in decision making. And that's also clearly stated now in our guidelines.
Yeah. Silvia, the patient values that are strongly mentioned in the AF guidelines, is that something that has the right focus from your perspective?
Absolutely. You know, the key point is the personalization of the approach. And that is where personalized medicine is going and where we should go. And it's particularly remarkable that this approach to individualize on patients' characteristics, the management, has been mainly done in simple diseases like the genetic diseases that are simpler because the variables are less. But now, with this task force, we are really entering forcefully in the application to acquired diseases and complex diseases. And just, I want to say that I have seen these guidelines yesterday, and I really congratulate with the team because they are amazing how the schematics, the ABC score, as you mentioned, very helpful for clinicians, easy to memorize, so we'll have a major impact. Congratulations.
I have to ask that question, Isabelle. How do we bring EAST in line with the guidelines?
Well, of course, it may be confusing now, but EAST is a special population, patients with cardiovascular risk factors, and it's patients with a short history of atrial fibrillation. And interestingly, 1/3 of the patients did not have any symptom. So it is completely in line with our guidelines, because if there is that first episode of atrial fibrillation, the wake-up call, then we have to start the holistic treatment. It is not, we are at the moment not sure whether it's really sinus rhythm that brought the benefit in the EAST. We have to look at that in more detail, of course. And I think, well, it is really a plea for a screening for atrial fibrillation in higher risk patients, and that is very well stated in the guidelines.
I fully agree with that perspective, and I think we need to take a close look to the results of EAST, think about it, discuss it with colleagues, digest. The calls from EAST, and then think about the impact it may have on the guidelines in the future. No, it's great science from EAST. It's great guidelines for the field of atrial fibrillation. So there has been tremendous, exciting clinical science presented today here in Amsterdam, but also basic science. And I would like to give the word to Silvia now to take a look for us to the basic science field.
Thanks a lot. You know, looking at the fact that breakthrough cardiology is the spotlight of the meeting, you know, we have had an excellent session that has shown us how translationals can be certain incredible breakthrough. So, for example, Dr. De Vries has been talking about the immortalization methods for cardiac myocytes. It means that you can take a cardiac myocyte that can also be a human cardiac myocytes derived from iPS cells, you know, so you can see all the combination of these advancements getting together. They've taken this monoclonal line of myocytes and they have immortalized them. So this opened the door to having a renewable source of cardiac myocytes that can be used for many different use, but you can see the regenerative potential of these. Then another aspect that is really incredible is the application of bioprinting. Bioprinting is really printing with biological ink. The ink can be the matrix of the heart, or and you print the cells. And what they have shown is that you can reconstruct the heart in what they call the organoids, that can be in smaller size but have everything. There is technology now to reproduce a heart with valves, with a coronary circulation, and more and more and more is being added. The objective there can be just to think about having hearts for transplants, renewable source, or having the heart of your patients replicated so that you can test the effect of drugs, gene therapies, whatever you can think of. So, really, who has missed this session should go and look for, because the future is bright.
Amazing. Thank you very much for these messages from Basic Science. Thank you, Silvia. Thank you, Isabelle, for joining us for this wrap-up of the first day here at the Digital Experience in Amsterdam. Stay with us for tomorrow. Tomorrow there is new exciting science coming up. Tomorrow the NSTEMI guidelines will be presented to the public, and a number of exciting and important clinical trials and late breakers will be shared with the community tomorrow. So thanks for being with us today, and stay with us for the next couple of days.